Good evening, everyone. Today we are having a subject seminar on shock. It's a very important question in your examination, and probably what's more important is we come across these patients very common in our clinical practice. So, without any further delay, Dr. Nikitha, can you please start?
Yes, sir. Good evening, everyone. Today's topic for subject seminar is shock. And so basically shock, throughout the history, the word shock has been used in medical field in a vague manner without proper specificity. Uh, so, okay. The word shock is originated from the French word choc, which referred to an encounter between two changing hostile forces. It simply meant collision, but medically it means a sudden debilitating effect produced over stimulation of nerve or pain or emotion. But more specifically, right now we are using with hemodynamic instability. So the contents of today's topic will be the definition of shock, basic pathophysiology, the indicators of shock, classification of shock and management. By the book, the definition of shock is defined as a state of insufficient perfusion and oxygen delivery to the tissues. Uh, there is a greater need for any medical practitioner to have a clear idea about shock because it's the most common and it is seen in many cases, like during accidents or mass casualties, or with the world being at war at one place or other. Every alternate victim is prone to have shock with a high mortality rate. So the good thing about shock is that it can be effectively managed provided that it is suspected early and can be minimized because it is time sensitive. And the pathophysiology of shock can be simplified by using this analogy. Here we relate heart to the pump, tank to the overall fluid volume in the body, and pipe to the blood vessels through which blood is being transported. So dysfunction of any one or more than these components lands the person in shock. So basically the critical causes of shock are dysfunction of any of one of these. So pump dysfunction means any difficulty induced by the heart. So it could be, the critical causes could be mechanical obstruction, acute myocardial infarction, or acute valvular insufficiency. And tank dysfunction could be like hemorrhage, blood loss, or hypovolemia due to other losses, and tension pneumothorax and abdominal compartment syndrome. Pipe dysfunction is basically on the blood vessels. They're affected by anaphylaxis, sepsis, or vascular catastrophes like ruptured abdominal aorta aneurysm and aortic dissection. These are all the diagnoses, but a patient won't be coming into an OPD or an emergency with a diagnosis written on his hand. We need to assess him in order to classify or diagnose him as a person who is having shock. So the parameters which are indicative of shock, this is a practical definition of shock. They have three components. The first component is cardiovascular compromise, in which the cardiac index, if it is less than 2.2 liters per minute, and systolic blood pressure less than 95 millimeter mm of Hg, and mean arterial pressure is less than 65 mm of Hg. The second component is signs of tissue perfusion. Central venous oxygen saturation being less than 65%, or mean mixed venous oxygen saturation being less than 60%, or lactate being greater than 2.2 millimoles per liter or equal to. Here, due to tissue perfusion, due to tissue hypoperfusion, the cells go into anaerobic respiration, which lands them in production of lactic acid. So lactic acid is an important component which comes across throughout the definition, assessment, as well as endpoints of the shock. And cold and clammy molted skin is also a sign. Organ dysfunction is the last stage of the shock, and which can be assessed by encephalopathy, lethargy, confusion. or urine output being less than 0.5 ml per kg per hour, approximately in a 60 kg old patient, 60 kg weight patient, it's less than 30 ml per hour is considered as low urine output and a sign of shock and liver dysfunction. So,
Nikita, one second. Any
yes,
doubts or questions so far from the postgraduate students? You can at least say yes, no, or at least put it up on the chat box so that we can go ahead. Indraja, you want to say something?
Sir, no, sir. Actually, I want to know central venous oxygen saturation and mixed venous oxygen saturation, sir.
Yeah. Nikita, can you take that question?
yes, sir. Central venous oxygenation and mixed venous oxygenation are basically measured by you drawing blood from the distal line of central venous catheter or pulmonary artery catheter, and we can send it for blood gas analysis. Through that, we'll know the values. The normal value of mixed venous oxygen is around 70 to 75%. Hypoperfusion, sir.
Yeah, I think we just lost you in between for a second. Anyway, okay. So far, just to summarize what Nikita has been, okay, first and foremost, she's a first year PG. I think she's doing her first seminar and she's prepared very well. What I want you just to reiterate or summarize whatever she said so far. Shock. Okay, in the body, there are three components. One is your heart, one is your blood or your intravascular content, and the last one is your blood vessels. So that is what she was trying to tell you between the pump, the tank, and the pipes. The pump is your heart, the tank is your intravascular component, and the pipe are your blood vessels. So any condition affecting either one of these three can eventually lead to shock. What those conditions are, we'll see in the coming slides. You can go carry on. Any comments from the seniors so far? Lakshman sir, Ravishankar sir?
I think Nikita, you started well. I think don't worry about there are obviously some stops that you make in the sense there is hesitancy, but that gradually as you keep presenting, you will overcome the hesitancy. I think the idea is good. The slide this one layout is good. So carry on. Good.
Nikita, just doing well. We usually measure the lactate not in the millimoles per liter, do we? What is our reading? I really don't know what the conversion is, so I was just wondering what that would be. Or maybe we should all look it up. Nishant, do you know?
Yeah, I think it is in millimoles only. I think lactate.
We measure in millimoles even here?
Yes, sir. Yes, sir.
Oh,
yes, sir. I too got the same doubt. Is it milli equivalents or millimoles, sir?
Yeah, because
basically, base deficit is measured in milli equivalents, but serum lactate is measured in millimoles per liter, sir.
Okay.
I looked it
All
up while
All
preparing, sir.
All right. Okay. Go ahead. Yeah.
Please carry on, Nikita.
I think only thing I have to say, I think that I read this in one of the latest articles on shock. Lactate is a very maligned, kind of, what shall we say, chemical component. But I think early lactate measurement, will help you to, manage shock better. So I think lactate should be taken very seriously. That is the message they were, basically trying to convey.
Yes, sir.
Thank you, sir.
So basically, types of shock they're classified by Cox and Hinshaw in 1972. Even after 4 decades, we are still following the same similar classification. The first one being hypovolemic, then cardiogenic, obstructive, and distributive. First, we'll discuss about hypovolemic shock. Hypovolemic shock, it's basically inadequate cardiac preload due to fluid loss. It could be either due to blood loss or other fluid losses. Blood loss is mainly by external bleeding or exteriorization of internal bleeding, which is melena, hemoptysis, hematemesis, and epistaxis. Or there could be some internal bleeding into the abdomen or into the hemopericardium or hemoperitoneum. And there could be some traumatic shocks because of traumatic injuries. Non-blood loss, fluid losses can take from gastrointestinal, renal, skin, and third place. Gastrointestinally, they are basically vomitings, diarrhea, and digestive fistulas. Through renal, it's due to diuretic usage, diabetes insipidus, and acute renal failure. It is in the primary phase of acute renal failure. Skin losses are due to overheat exposure and burns and excessive physical effort. And third space sequestrations are basically peritonitis, ascites, pleural effusion. So with these causes, a person walks into the ER, but how to identify? How to identify whether he is having shock or not? He will have some presentation which is very closely related to any of the causes which we have mentioned before. But other than that, when he walks in, we'll check how can we classify based on routine vital readings. So he presents with increased heart rate, that is tachycardia. Then his BP will be low, temperature decreases, SpO2 decreases, respiratory rate increases, and bedside physical examination gives us these measurements. Due to recent advances and through the calculations with the given vitals, we can derive shock index, modified shock index, and perfusion index. Recently, flatness index and the polytrauma is being used to categorize or to identify the patient who is suspected to have been in shock. Shock index is heart rate. It's a ratio of heart rate by systolic blood pressure, whereas modified the shock index is heart rate by mean arterial pressure. Perfusion index is ratio of pulsative blood flow to the non-pulsatile blood flow. Flatness index is calculated by computerized tomography on the inferior vena cava. So by that we have suspected that the patient is in shock. In order to manage the patient, we need to know the level or the class of the hypovolemic shock he is in. Based on decreased plasma volume, we can classify the patient into 4 categories: class 1, 2, 3, and 4. The first one is 15 loss less than 15% of, and second one is 15 to 30%. Third one is 30 to 40. Fourth one is greater than 40% of volume loss. In class 1 with 15% volume loss, he will present with approximately 750 ml of fluid loss, with heart rate being less than 100 ml, BP being normal, and mental state being alert. Extremities are normal in this case. In class 2, the blood loss will be around 750 to 1500 ml. Heart rate will be greater than 100 per minute, which is tachycardia by now. And BP is normal in this class also. Respiratory rate increases greater than 20 per minute. Urine output slightly decreases, and his extremities are pale. In class 3, the loss is nearly 2000 ml. Heart rate increases more than 120. BP reduces from class 3, and urine output is further reduced, with the mental status being very drowsy or aggressive in this case. Class 4, it's the last class with volume loss being greater than 40%, and heart rate increases to 140. Urine output further decreases to 10, and mental status is unconscious or confused in this case with cold extremities. Hypovolemic shock can also be called as cold shock because the person's extremities are very cold when he presents. In recent edition of LTS, they have added base deficit into this classification system, with class 1 having less than or equal to 2 milli equivalents, class 2 2 to 6, class 3 6 to 10, and class 4 greater than 10 milli equivalents. Why do we classify into 4 classes? Because it helps in the management. In class 1, we just need to monitor the patient. But if he is categorized into class 2, there is a possible transfusion, we need to get the blood products or the things need to be arranged. And in class 3, we need to transfuse the patient. In class 4, the massive transfusion is advised. So management of a hypovolemic patient starts with the basic ABCD, but extra there are 2 more. Airway is need to be secured, and SpO2 of greater than 95% is advised to be maintained. The blood breathing needs to be addressed. Disability, any neurogenic disability, if he is presenting, we need to keep on re-examining to know whether it has worsened or it has been reversed. E means exposure, in which we try to expose the whole body of the patient and find any bleeding site or any external injury which we are not supposed to miss. D is decompression of gastric decompression. We do this in the patients who are unconscious to prevent aspiration, which further leads to pneumonia. And UC is urine catheterization, because as the patient is unconscious, and as well as it is a very important parameter for monitoring, we catheterize the patient. And immediately we put large bore needles and isotonic crystallite infusion. Nearly 13 ml per kg per body weight is given at stat. Infused crystalloid only stays 1/3 of the amount we infuse. So we infuse 3 times that of lost volume in order to replenish the lost volume. Colloid solutions, which were previously used, now they are not recommending, because it causes it was found to cause acute kidney injury for post transfusion. So in the process of transfusing everything, our target is to achieve the mean arterial blood pressure of at least 65 mmHg and a urine output greater than 0.5 ml per kg per hour. So how do we transfuse the crystalloids? We can't directly transfuse how much ever we want, because it lands the patient in
Nikitha,
1 second.
the fluids are infused, not transfused. Only blood is transfused.
Okay,
So
sir.
I think the term used for colloids and crystalloids is infusion, and for blood it is called transfusion.
Okay, sir.
Yeah, Nikitha, 1 second. Let's just take a pause before we go into the resuscitation part of it.
Yes, sir.
PGs, any doubts so far before we start asking questions?
No, sir.
Okay, Indraja, because you volunteered, I'll ask you first. Okay.
Yes, sir. Yes.
As a postgraduate in hypovolemic,
Yes.
okay, first and foremost, before I get to you, just one clarification. When Nikitha was talking about the classes, that is with respect to blood loss. That is not
Yes, sir.
applicable for GI fluid loss and renal parameters and stuff like that. That is only for blood loss. Now, if a patient with a polytrauma comes to you,
Yes, sir.
okay, in shock, what are the first things that you're going to do?
Sir, first, after checking the vitals, we should put the large wide bore cannulas. Then we'll start the fluids. We should transfuse the fluid. We should infuse the fluids. Yes. Then we have to check for the injuries, sir.
Indraja, go by the ABCDE. I think it's
Yes,
very
sir.
important.
Airway. Yes, sir. Airway, and
Okay.
we should
What is
assess.
B?
Yeah, A, B, C, D is done. You're going to secure a cannula. Next.
And
Cannula is over. Next what?
mm,
What is the most important as a surgeon? If you see the patient bleeding, what will you do?
so we should control the bleeding, sir.
Correct. That is something that is missing here. Nikitha.
Yes, sir.
Okay, you have done very well, but that's an important point. When you find a patient who's bleeding, put pressure. Try and stop the blood loss. It's not only about resuscitating the patient. Resuscitation should go side by side along with stopping the ongoing blood loss.
Yes, sir.
Okay, and catheterization, like you said, is only for people who are unconscious or who are in severe shock. That probably class 3 or class 4. Class 1 and class 2 can be managed without catheterization because you don't want to unnecessarily or undue give risk of infection in such patients. And that's about it. Yeah, you can finish the resuscitation, then we'll get back.
Yes, sir.
Nikitha,
Sir,
why do you think they added this base deficit to the classification of shock?
sir, because of
Anybody else?
There were few studies which said that taking base deficit as a parameter makes the patient inclusive if the other parameters are not considerable. It's one of the acute, sir. I'm not very...
Nikitha, I'll help you work it out.
Okay.
You define shock in the first slide as what?
Tissue hypoperfusion and decreased oxygenation, sir.
Excellent. So when you have tissue hypoperfusion, what happens?
Decreased oxygen supply to the tissue.
What happens after that for the metabolism?
Anaerobic respiration.
Yes, lactic acid
increases.
increases. So you also mentioned about the importance. So when a fixed acid like a lactic acid is going into it, what happens to the base in the acid-base equilibrium?
Base decreases, sir.
Yes, so there is a base deficit.
Yes, sir.
So what are you measuring here? What are you saying now? Base deficit is a parameter. Okay,
yes, sir.
For the severity. So the more severe the base deficit is, higher is the
shock.
Higher is the shock, or higher is the degree of
Tissue,
hypoperfusion or tissue oxygenation. So more severe is the shock. Okay, that's why in the ATLS system they have included base deficit also. All right.
Yeah. I just wanted you to understand.
Yeah. That
what
see,
you are aware.
Ravi had an excellent point. You must reason these things out. You shouldn't mug it up. Okay,
Yes,
that's a very important thing. Yeah. Go ahead, Nishant, please.
Go on, Nikitha, please carry.
Sir. Damage control resuscitation. Okay, what is the damage which we are controlling? It's the damage is basically due to the triad of death, in which due to severe blood loss. One person often develops the lethal of triad of coagulopathy, hypothermia, and metabolic acidosis. Each one precipitates the other, and cascades into an irreversible shock. So we are trying to prevent one of the most treatable arm of the triad of death, that is coagulopathy, by following damage control resuscitation. The components of damage control resuscitation are limiting the crystalloid and permitting hypertension. And by limiting the crystalloid, we permit the hypertension. Our goal is to maintain only greater than 65 mm of Hg of mean arterial pressure, or greater than 90 to 100 mm of Hg of systolic blood pressure. If it is greater than that blood pressure, the person might end up having the rebleeding of the rebleeding from the site of injury. And the balanced resuscitation is being followed now, in which the plasma, platelets, and PRBCs are in the ratio 1:1.
Yeah, Nikitha, just go. Sorry, go on, Ravi.
No, sir, you finish.
Yeah, just
if I can come in, Nikitha, can you? I think she's got a bit confused with this concept. Okay, just move on to the next slide, Nikitha. 1 second.
Nishant, with your permission, I needed her to go to the this is the previous slide actually.
Okay.
You talked about the coagulopathy, acidosis, and what was the third component?
Hypothermia, sir.
Hypothermia. And you talk about the decreased heart performance. Why does that occur? Why does the heart perform less well? It's because of acidosis.
Acidosis.
Okay, acidosis reduces the metabolism everywhere, and the heart does not pump as well as it ought to. So that is something you must understand. All right. Yeah.
Yes.
The next slide. Yeah. Next slide. You were talking about permissive hypotension. One of the easiest ways to remember, you mentioned it correctly, but one of the easiest ways to remember is like filling a bucket with a hole. Okay.
Yes.
So you have a bleeder somewhere, and you keep, and nature has reduced the blood pressure and reduced the leak from that hole, which is the injury or injury to the vessel or whatever, injury to the tissues. And you keep increasing the blood pressure without controlling the bleeding, then you're only pouring fluid into a hole with a bucket with a hole. That is where the concept of damage control and permissive hypotension came. The purpose of this is to keep the patient alive with just enough blood pressure to keep the brain, the heart, and the essential organs supplied with blood. And then you stop the bleeding, and then you can go ahead and improve the blood volume with a bigger transfusion if required. Okay.
Okay, sir.
So where is this concept of balanced resuscitation? Why are you not giving whole blood?
Uh, First point is
Anybody? Go on.
limited availability of whole blood, sir.
Okay.
And second one is the preservatives of the whole blood.
No, what are the components of whole blood, Nikitha?
Yeah. All right.
In blood, what are the components in blood? RBC?
RBC, WBC, platelets, and plasma protein.
Correct. Correct.
So what is missing here?
Pawan, you want to take that question?
WBC.
No,
Sir, instead of whole blood, if the patient having only blood loss and all, we can replace the blood with only PRBC, and clotting profiles depends on the INR. We can able to transfuse the plasma.
no,
and
that is not the question. No, I'm talking about why are you not giving whole blood? It has to do with the blood banking policy, which has evolved over the last 30 years. Okay. Anybody aware of it? Indraja?
No, sir.
Yeah. The whole point is that today we are into what is called component therapy. So no blood bank holds stores whole blood. As soon as they collect the blood, they separate it into plasma and RBCs. If necessary, they have platelets. They'll have pharesis or whatever to do the platelets. They may even have white cell concentrates in rare situations. It's not very common. It is because of that this is required for optimal use of blood. If you look at the agenda for a blood bank, it has lots of requirements, not only patients in shock needing blood. Okay, so they will use the blood optimally with their components. Give platelets to people who want platelets, give RBCs to people who are anemic. Okay, give fresh frozen plasma to people who have coagulopathy. So they're making optimal use of the blood that they collect. But in a patient who has a hemorrhagic shock, he does need all the components. So instead of storing whole blood, which they have built into, which they have split into components and distributed, they'll reconstitute the whole thing in a proportion that is normally seen in nature. That is why you have a 1 + 1 + 1 for plasma, platelets, and RBCs. And then they give you the you reconstitute the blood by giving these three components to the patient. Are you with me on that?
Yes, sir.
Yeah, fine. Please go ahead. Nishant.
Yes, Nikitha, the previous slide, the triad of death. Nikitha, you there?
Yes, sir.
Yeah, can you
Go
just
back to the previous slide.
the triad of death?
Yes, sir.
She's probably not able to go back.
Okay, anyway,
Sir, I have tried of death only, sir.
can you just stop sharing and reshare your screen? It's come.
Okay, sir.
Okay. Do you have anything more to say here, or are you planning to go on to the next one? Nikitha?
Please answer, Nikitha.
No, sir.
If you have nothing to say, say nothing.
Increase increased infusion of crystalloids causes decreased coagulation, sir. That one point I thought of saying, sir.
Okay. Pawan, can you tell me why increased, like she just said, increased crystalloid will cause decreased coagulation? Why is that? Pawan, are you there?
Sir,
Yeah.
I don't know, sir.
Yeah.
Indraja?
Sir, she had one call from emergency, sir. She
Okay.
went.
Vinod?
Vinod is not there, I think.
Okay, done.
He's,
So see, the concept is very simple. Whenever you have coagulopathy and you dilute it with excessive of crystalloid fluids, the coagulopathy will come down. And the whole idea is the patient is bleeding, so you don't want the patient to go into coagulopathy. And second thing is with respect to hypothermia. Again, Pawan, because you're the only one here. Why is hypothermia dangerous for the patient?
Sir, hypoxia, hypoxic ischemic encephalopathy.
No, actually, hypothermia is good for organs. No, if the metabolism comes down, the chance of death, cell death will be low. It actually has to, again, all this eventually comes down, boils down to coagulopathy. When in the presence of hypothermia, your enzymes, no, which are responsible for coagulation, they don't work that well. They work in a very narrow window. So that's the reason they say avoid hypothermia, and as much as possible, you infuse warm fluids for the patient. And and I think there's just one more change where you said that fluid of 30 ml per hour is given as a resuscitative measure, 30 ml per kg.
Yes, sir.
Okay. I think the recent update to that is that you just give them about 250 to 300 ml of bolus. That is because let's assume it's a 60 kg person. So 30 ml into 60 is about 1 liter. And they say that sometimes you might overload the patient. So they say give them 250 to 300 ml, wait and watch, look at the response. If the response is good, continue with the resuscitation. If the response is bad, what does that mean?
Then it is not
It
ongoing
is
loss.
shock, but it is not something that can be managed with only resuscitation.
Yes.
That is when your surgical intervention comes into picture. Okay.
okay, sir.
Yeah. Please carry on.
Nishant, can I
Yes,
just
sir. Yes,
see
sir. please.
this principle of permissive hypotension, I think came from the ruptured aortic aneurysm. So when there is ruptured aortic aneurysm, you tend not to increase the blood pressure to beyond 90 or mean arterial pressure beyond 60. And because as Lakshman sir said, it should continue the perfusion to the brain, to the heart, and maybe the kidneys. And then once you got the cross clamp across the ruptured aortic aneurysm, then only give blood and other fluids. So I think that from that concept, I think and probably from trauma as well. I think those are the two areas from where this major contribution has come, and I think that is the right thing to do.
Yeah. Nikitha, do you have a slide on massive transfusion protocol?
No, sir. I just mentioned it as a point, sir. Not no, I don't have a lot of information of massive transfusion protocol, sir.
Can you define what is massive transfusion?
Greater than 10 units of blood transfusion within 24 hours, sir.
Or
Or
more than
greater
4
than
units?
the body's volume, greater than the whole blood volume of a person has been transfused.
Also more than 4 units in 1 hour. And if I'm not wrong, this idea of balanced resuscitation of 1:1:1 came with or is a part of massive transfusion protocol. We don't do this in routine for everyone.
Okay, sir.
Okay. And
Yes.
what else is a part of this massive transfusion protocol? When you give, what else are you supposed to give apart from blood and blood products?
We are supposed to give some adjuvant, sir.
Like?
Calcium gluconate
After how many units of blood do you want to give calcium gluconate?
I'm not sure, sir.
Pawan, do you know the answer?
No, sir.
After every 3 units of blood, you need to give 1 unit of calcium gluconate. Do you either of you guys know why we are giving calcium gluconate?
Yes, sir. Because of the transfusion, the intracellular calcium will be paired up with the preserving component of the blood preservative, sir.
Yeah,
So-
that's basically citrate.
Citrate,
Citrate is
citrate.
the preservative in the blood. Citrate is a chelating agent.
Citrate.
Okay, yeah. Please carry on, Nikita.
Yes. The other adjuvants which we use in resuscitation are whole blood, massive transfusion protocol, which sir has explained now, and viscoelastic hemostatic assays are recently being used to find out the clotting system, clotting capacity of the person, and hemostatic adjuvants are also being used now, which we see in our day-to-day surgery practice, like gel form or surgi gel, and tranexamic acid, vitamin K, recombinant erythropoietin, and calcium gluconate after blood transfusion. Warmed
Yeah,
intravenous
Nikita, I'm interrupting you because the hemostatic adjuncts that you're mentioning in this context does not include gel foam and things like that. Okay. This is only that is for local control. Here you're talking about the stability of the clot. That's where you're using the adjuncts. Okay. So as you understand, there are two components. One of them, as a surgeon, you open up the patient, we will not go into it now, but you use several mechanisms to stop the bleeding. That is one, and that is where all the adjunct you talked about, like the gel foam, comes in. But here these are chemical agents, medications, which either help the blood to clot or make this clot more stable.
Okay, sir.
All right. Yeah. Go ahead.
Sir, are there any examples, sir, to be specific medications, hemostatic medications, sir?
Tranexamic acid. Oh, hemostatic agents.
Okay. Okay, sir. Warmed intravenous fluids and heating blankets to the patients with hypothermia. These are to be given. So after starting the management, we need to start monitoring the patient in order to know whether he's being whether he's being responsive to the treatment or there needs to be any change of treatment. So the standard method, standard monitoring things are conventional vital signs like heart rate, blood pressure, body temperature, and oxygen saturation, and ECG, and fluid intake and output charting, and laboratory monitoring like complete blood count and blood gases analysis, capillary refill. But in the recent advances, they have also been monitoring the height of jugular venous pulsations and central venous pressure and central venous oxygen saturation and mixed venous oxygen saturation, pulmonary artery occlusion pressure, serum lactate levels. And these are the very recent advances and of high technology with very minimal invasiveness, sublingual capnometry, gastric tonometry, tissue electrodes, and laser Doppler flowmetry. Sir, do you want me to say a word about every single
No,
one?
I think because we still have septic shock to cover, we'll get back to this. Yeah.
Okay, sir. So resuscitation add-ons, hemoglobin has a very dubious role, and hypotensive patient, this is the old one which they said that 2 liters of crystalloids to be used, and in critically ill patients, if the hemoglobin level is between 6 to 8, then transfusion is advised. And Mayer and others study by Mayer and others showed every minute before volume resuscitation in hypovolemic shock increases the mortality risk by 5%. So this again proves that the shock treatment is time sensitive. So endpoints of resuscitation are monitoring pH, serum lactate, base deficit, ECG, arterial wave analysis, and tissue saturation levels. Then I want to talk about septic shock. Sepsis is defined as a life-threatening organ dysfunction caused by dysregulated host response to an infection. So organ dysfunction can be identified by SOFA scoring, which is sequential organ failure assessment. If the score is more than 2 points along with infection, then a person can be considered as in septic shock. SIRS criteria which was used previously is obsolete now. Septic shock is sepsis plus requirement of vasopressor despite fluid resuscitation. SOFA components are respiratory.
One second. Before you move ahead, do you have a slide which tells the difference between SIRS, sepsis, severe sepsis, and septic shock?
No, sir.
No. Okay. Pawan, if you're there, can you please elaborate what SIRS, sepsis, severe sepsis, and septic shock is?
Sir, sepsis means
What is SIRS?
sir,
SIRS,
what is
SIRS,
it?
systemic inflammatory response syndrome. What are the components?
sir, that is sepsis plus any foci of infection is there, sir. And systemic.
No, Pavan. SIRS need not be septic. All right. So we must start with what are the things that tell you that a patient has SIRS, SIRS.
Yes, sir. Sir, patient having sepsis
Temperature
with-
is one of them. Again, you're talking
Yes.
about sepsis.
First is
Systemic inflammatory response syndrome.
No.
Okay. What are the parameters, patient parameters that you check on that? Temperature is one. I'm giving you a hint. Go on. Tell the others.
temperature, respiratory rate,
Uh-huh.
and pulse rate, sir, and WBC count.
Yeah. Okay. So go on, Nishant. Yeah.
yes, sir. So each of those parameters have so temperature more than 100 or less than 96 Fahrenheit, then respiratory rate more than 20, then your heart rate more than 90, WBC either more than 12,000, less than 4,000, and I think even PCO2 is also taken into consideration. Okay, so these are the components that you look for in SIRS. Then what is sepsis? Pawan or Nikitha, even
Pawan,
Nikitha, you can take the
yeah.
answer. if you know it.
Two or more than 2 components of SIRS are considered into sepsis, sir.
Plus what? What is the extra
Plus
thing? in
infection.
Less
Organ
infection.
dysfunction.
Correct.
sepsis? Correct. And severe sepsis?
Organ dysfunction, sir. Any of
Correct.
Sepsis plus organ dysfunction. And septic shock?
more than one
Organ.
organ, multi-organ dysfunction, sir.
No.
That is
Plus. Go on, Nishant. Yeah.
persistent organ dysfunction and persistent hypotension.
Okay.
Shock. You there, Indraja? Did you understand?
Yes, sir.
So SIRS are those 4 components.
Yes, sir.
Sepsis is 2 of those components plus suspected or confirmed infection. Septic severe sepsis means there is some sort of organ damage going on, and in septic shock there will be hypotension with
Persistent organ
infection with end organ damage.
Yes.
Okay,
Yes,
sir.
sir.
Anything else to be added to that, sir?
That's it. That's fine.
Yeah. Please
So,
carry
so
on. Oh, sorry,
Nikitha, you just said now that SIRS is now no longer in vogue, and SOFA has come into prison. So why do you think that is?
I think maybe because SOFA is more sensitive, sir. It has extra components which are being included. That's it, sir.
Sir, can you give the answer, sir? I don't think she knows.
No, I actually, honestly, I don't know why SOFA is preferred over SIRS. I thought she probably, because she made that bold statement, so I thought she probably knows the answer.
No, I think the trend is right that they have included more components now. For
Okay.
example, the mental status. They have also included the renal output. So this is studies would have shown that this is more accurate in grading and evaluating the response to
Sepsis.
treatment in sepsis. Yeah.
Go on, Nikitha.
Go on.
The components of SOFA are respiratory, coagulation, liver, cardiovascular, central nervous system, and renal, each one having a score of 0 to 4. And with the but recently we have been using quick SOFA criteria, which includes only 3 components, that is respiratory rate greater than or equals to 22 per minute, or altered mental status with GCS being less than 15, or systolic blood pressure less than 100 mmHg.
Go on.
Sepsis Surviving Campaign has introduced 3 bundles, introduced 2 bundles initially, and 1 more bundle has been recently updated. The first bundle consists of, it's basically the management of a sepsis patient. In the first 3 hours, we need to evaluate the serum lactate levels, and the culture and sensitivity of the blood needs to be sent, and antibiotics need to be, sensitive antibiotics needs to be started. The patient needs to be started on sensitive antibiotics, and resuscitation should start with 30 ml per kg. Within 3 hours, he need to be completely resuscitated if the lactate is greater than 4 millimoles per liter. In a 6-hour bundle, even after the resuscitation of first 3-hour management, if he does not maintain his mean arterial pressure greater than or equals to 65, we need to use a vasopressor. But in the recent update, they are suggesting that 1-hour bundle needs to be used for the management, which includes both the first and second bundle, in which within an hour a person's lactate needs to be elevated, antibiotic needs to be sensitive antibiotic needs to be known with administration, and resuscitation should be done. And if the BP is not maintaining within the values, then vasopressor needs to be introduced.
Nikitha, I think you can't say that the antibiotic should be, sensitivity should be known. How can you know sensitivity within 3 hours? So you should say possible antibiotic, that possible bacteria that is likely to cause. For example, if it is a skin organism, then you know it usually staph or staph. And if it is gut organisms, either in the peritonitis or urosepsis, it is Escherichia coli or Klebsiella or Proteus, things like that. So you need to address the possible organism, and depending on the degree of the shock, the antibiotic, the dictum will be hit them early, hit them hard, and keep hitting them. So that should be the dictum. And then, of course, you send the blood for culture, urine for culture, and anything else available, you send it for culture. And as soon as you get the sensitivity, you then either escalate or de-escalate depending on what the organism has shown and also the condition of the patient. If the patient is already responding, then you need to decide whether you should continue the same antibiotic or de-escalate or whatever. So that should be the thing. And I think this waiting for 3 hours to before you start vasopressor is probably wrong. I think that is why the third thing comes in. In some patients, you may have to start the vasopressors much earlier than that.
Yes, sir.
Okay. For want of time, I would like to explain this slide. And I think it's called the Surviving Sepsis Campaign. It's not the Sepsis Surviving Campaign. And first and foremost, you need to understand what the pathophysiology of a septic shock is. In the presence of endotoxins in the blood, okay, most commonly seen with gram-negative bacteria. So what happens is there is a lot of inflammatory response and cytokines which are produced from the body. So these cause vasodilatation. That's the first point. Second thing is, when they have vasodilatation, there is a lot of space between the endothelium cells. So there is a lot of leakage of intravascular volume to the extravascular volume. Okay. So even in a patient with septic shock, the patient is hypovolemic when you take the intravascular volume into consideration. Okay. And when they say this 3-hour bundle, 6-hour bundle, it basically means that whenever you get a patient in sepsis, these are the things that have to be completed within 3 hours. It doesn't mean that you take your own sweet time, or you take 3 hours, or you take 6 hours to do this. Within 3 hours, you're supposed to do this. And like sir said, you take a culture before you start the antibiotic, and you start the patient on a broad spectrum antibiotic, assuming what the source of infection could be. Okay. And then switch over to the appropriate antibiotic once you have the culture report available with you. And meanwhile, that is the reason why they've said give fluids of that 30 ml per kg, Because even though it is septic shock, we know it's vasodilatation where the systemic vascular resistance is low. Even now, the patient is hypovolemic. So you give them fluids, see how they respond. If they don't respond, only then you go on to vasopressors. Okay, in spite of giving fluids, if the urine output is low or if the mean arterial pressure is less than 65, then you move on to vasopressors. Do you have a slide on the vasopressors?
Yes, sir. Not exactly a slide, sir. Just
Okay, then I'll just cover it up then. So now what is in the recent 2021 guidelines, what there is 3 hours and 6 hours, they said, no, we can't afford to wait so long because like you said, mortality is very high. The longer you wait, the higher is the chance you're going to lose the patient. So they combined all of these and they've said that kindly do this within 1 hour of you getting the patient. Okay, so don't wait for such a long time. Start all of them together, give him a fluid challenge, see if he or she maintains their BP. If they don't, shift on to vasopressors, apart from doing the other investigations as mentioned. What are the vasopressors that we use?
sir, norepinephrine, the 4 vasopressors we use, sir, in general: norepinephrine, phenylephrine, epinephrine, adrenaline, sir.
And
Dopamine, dopamine.
vasopressin.
Yeah.
Yes, sir, vasopressin.
Why is it that we use noradrenaline most commonly?
I'm
Over
not sure,
adrenaline.
sir.
Why do we use noradrenaline over adrenaline?
Not
Pawan?
sure, sir. No idea.
Pawan?
So not sure, sir.
Okay. See, adrenaline has both alpha and beta agonistic activity. Okay. Where are the alpha receptors? Where are the beta receptors? Okay. Alpha receptors are on the blood vessels. Beta receptors are in the heart. Adrenaline has effect on the both. Okay. So it also causes vasoconstriction. At the same time, it has a chronotropic effect. So assume the heart keeps on pumping very fast. Will the pumping be effective or not?
It's not effective, sir.
Correct. That's why we use noradrenaline, because it has weaker beta agonistic activity. That means it has a mild chronotropic effect, but not to the extent what adrenaline has. So in other terms, if you give adrenaline, you have a risk of the patient developing arrhythmias, which is a component of cardiogenic shock. Okay. So that's the reason the ideal choice of vasopressin or the ideal inotropes that we use is noradrenaline. Please go on.
Okay. So the management includes basically the components of the bundle itself, with fluid resuscitation, antibiotics, vasopressor. In a few cases, we use corticosteroids like hydrocortisone. We address if the patient has any known case of diabetes. We need to address the hypoglycemic state, and if there is any need for blood transfusion, and the nutrition of the patient needs to be considered. Stress ulcers are the people are more prone for stress ulcers, so prophylaxis needs to be given. The next one is cardiogenic shock.
One second, Nikita. I think there is a lot of things that we have missed in septic shock. It's a very important topic. Okay. Even if it means we miss out on one type of shock. Sir, can we extend by about 10-15 minutes, sir?
Sure. Go ahead.
Yeah. Nikita, you have spoken about management. In
Yes,
general, in your examination, when they say management, what are the components under management?
investigations and
Correct. So how are you going to investigate this patient? So when you say talk about sepsis, what are you looking for?
we are looking for an infection, sir. So
Correct. So what all are you going to do?
Sir?
So what all are you going to do? What all investigations would you like to get?
Complete blood picture, urine, routine and cultural sensitivity, blood culture and sensitivity.
Correct. Next. If the patient has pneumonia.
Yes, sputum cultural analysis.
Chest X-ray, CT test. In
Yes,
the abdomen, appendicitis or cholecystitis.
USG, ultrasound.
Correct. And or CT of the abdomen. Okay.
Yes,
so
sir.
This is identifying the source of sepsis. As a surgeon, you have a role in controlling the sepsis.
And treatment.
Okay, so there is
Okay.
also something called surgical control of sepsis. No, if there is a perianal abscess, you need to drain the abscess. If there
Yes,
is
sir.
gangrenous cholecystitis, you need to go in and do a lap chole. Gangrenous appendicitis, appendicular abscess. Okay,
Yes,
so
sir.
those are your surviving sepsis campaign only tells you about the medical line of management, but you also need to be aware that a surgeon has to be actively involved in source control
Okay.
of sepsis. Okay,
Yes.
and one more point regarding this corticosteroids. Do we routinely give it to everyone?
No, sir.
When do we give it?
If you are sure that the patient is not immunocompromised and even after the use of the antibiotics, when the sepsis infection doesn't come down.
See, no, the idea is you give the patient vasopressors, you have given antibiotics to control the infection, correct?
Yes, sir.
But sometimes it is so bad that you need to use very high doses of inotropes. Okay, so in spite of tackling or giving the right antibiotics, in spite of controlling the source of sepsis, such as either through surgical or through medical management, in spite of all this, if the patient's vasopressor or inotropic need is very high, only then you are allowed to use steroids to help reduce the dosage of inotropes required. Because the higher the dosage of inotropes you use, more is the chance of the patient having arrhythmia. So lesser is the pumping action of the heart.
Yes, sir.
Okay, that's
Yes.
the reason. No, otherwise, in infection, do you want to use steroids?
Yes, sir.
No, no. In infection, do you want to give steroids?
Provided that it is demanded, then
Yeah, in general, infections flare up, no, the presence of steroids.
yes, sir.
So this is one area where you are allowed to use steroids even in the presence of an infection in order to reduce the need for inotropes.
Okay, sir.
Nikitha,
Sir?
to add to what Nishant has said, earlier there was a concept that if you give large doses of steroids, they used to use methylprednisolone 1 gram, okay, which is a very large dose. If they did that, they felt that it would help in reducing the release of these cytokines that Nishant talked about, and would help the survival of septic shock, but it was proved incorrect for a course of time. And now you can see on the slide, the concept of giving steroids is that there is a hypoadrenalism in sepsis. Okay, the adrenal doesn't function the way it ought to. So you're only supposed to give what the adrenal would normally give in a day. That's all there is to it. 200 milligrams of hydrocortisone a day is all. It's a very small dose, and the logic is now not one of attenuating or reducing the cytokines, but one of adrenal replacement. Okay?
Okay, sir.
All right. Nishant.
See sorry, Nishant, just I think to just add to the points are made. I think if you are using these inotropes, apart from I think the main organs, there is peripheral vasoconstriction, there is splanchnic vasoconstriction, so the blood supply to adrenals and everything comes down. So basically, because of that, I think that is one of the reasons why you have to supply the daily output of steroids.
Yeah, Nikita, can you quickly wind up on cardiogenic shock and obstructive shock?
Yes, sir. Cardiogenic shock, it was initially defined by shock trial as systolic blood pressure being less than 90 for greater than 30 minutes and urine output being less than 30 ml and with cardiac index less than 2.2. Pulmonary capillary wedge pressure being greater than 15 millimeters per mm of Hg. But new update, the new trial is being for KMIR NIH with systolic blood pressure less than 90 for greater than 30 minutes with evidence of end organ damage, which is altered mental status or urine output less than 30 ml or cool extremities. It has been classified into 3 types, which is cold and wet, in which there is a pulmonary congestion, and dry and cold. In this, the patient is euvolemic but presents with shock, and wet and warm is basically the sepsis shock. Management of patient with cardiogenic shock. we'll use vasopressors like norepinephrine and dobutamine to increase the contractility of heart. Milirone is which inhibits cyclic AMP. It's also used to increase the intercellular calcium. In the case of myocardic infarction, fibrinolytic therapies are used. Aspirin and heparin has been provided to have good results. Diuretics are also used in intention that they'll decrease the edema and plasma volume, which in turn is helpful for the overall functioning of heart. And therapeutic hypothermia is given only in the cases where there is an extra hospital cardiac arrest of the patient, and in order to keep him with a shockable rhythm. To prevent the brain injury, we give a therapeutic hypothermia in the case of cardiogenic shock. And the other one is obstructive shock, which is...
Nikitha, just 1 second. So in short, cardiogenic shock means basically the heart is not pumping. So like we spoke in the beginning, it's the pump, the tank and the pipes. So the pump is not functioning and you end up with hypotension because of that. It's called cardiogenic shock, either seen in arrhythmias where it's not contracting in rhythm, or in an MI where the heart itself is not pumping. Okay, so for that you're going to use various types of inotropes, or if there is a myocardial infarction, you're going to use fibrinolytic therapy. Yeah, please carry on, Nikitha.
Obstructive shock is extracardiac, which is basically the pipe block. The findings are decreased or missing respiratory sounds and pulsus paradoxicus, because the one of the cause of obstructive shock is the pneumothorax, and subcutaneous emphysema and hemoptysis because of pulmonary embolism, one of the cause being pulmonary embolism. Investigations which we use in the obstructive shock are rapid ultrasound of shock and hypotension, and transthoracic echocardiogram or transesophageal echocardiogram, and point of care ultrasonography in the CT pulmonary angiography. The management is being resuscitation and use of vasopressors and inotropes, mechanical ventilation in few cases, and extracorporeal membrane oxygenation in very end stage cases. Though not mentioned, ABCD are very crucial in all the management, in all the cases of management. The specific treatments for the pulmonary embolism being use of anticoagulants in tension pneumothorax. In a non-hospital setup, we need to do emergency needle decompression, and in a very aseptic conditions, if they are available, chest tube placement is advised. In cardiac tamponade, percutaneous pericardiocentesis is being done for the management. The last one being distributive shock, which includes septic, neurogenic, and anaphylaxis. Septic has been discussed already. The neurogenic shock is due to loss of sympathetic tone of the blood vessels, and due to unopposed parasympathetic tone, it causes vasodilation, which causes the pooling of blood in the blood vessels, decreased preload, and results in the shock. Anaphylaxis, in other words, it causes vasoconstriction due to histamine release. There is one more shock, which is endocrine shock, which is mixed, in which the components being thyroid and adrenal gland. In hypothyroidism, we get it presents as a cardiogenic shock, and in hypothyroidism, it mimics septic shock, whereas Addison's disease mimics hypovolemic shock because of vomitings and diarrhea. Distributive shock is basically due to decreased peripheral vascular resistance. And, thank you.
1 second, Nikitha, can you just go back to your obstructive shock slide? Yeah, that one. Next slide, please.
Yes.
Pawan, are you there?
Yes, sir.
Next slide, Nikitha. Go to the final slide of obstructive shock. Can you tell me how tension pneumothorax causes obstructive shock?
Sir, in tension pneumothorax, there is a loss of there is increased intrapleural pressure, sir. So the venous return will be decreased. So cardiac output also decreases, sir.
Correct.
So that leads to tissue hypoperfusion, sir.
Okay, and in cardiac tamponade?
In cardiac tamponade, if there is any collection around the heart is not able to pump properly or not contract properly, so that there is a reduced cardiac output that leads to tissue hypoperfusion.
Yeah.
Sir.
So what are the findings in a cardiac tamponade? There are 3 typical characteristic findings. Do you know them?
Sir, one is increase visible veins, sir. Visible veins, that is raised visible,
Correct.
visible veins, and pulses paradox. Yes, sir. One
Hypotension and muffled heart sounds.
muffled
Muffled
heart
heart
sounds.
sounds.
What is this
Yes.
called?
Beckstride, sir.
Correct. So just to reiterate, in tension pneumothorax, what happens? There is shifting of mediastinum. So because of that much pressure, both the IVC and SVC can be narrowed. So there is decreased blood into the heart. So automatically, when the end diastolic volume is low, your cardiac output will be low. Then the patient will have hypotension. So to rectify that, you need to do either a needle decompression or put an ICD. In a tamponade, like we just discussed, there is a lot of fluid around the heart which doesn't allow the heart to expand. So again, the end diastolic volume or the filling inside the heart is low. So you need to do a pericardiocentesis and release that fluid or blood around the heart to allow the heart to pump. Now, with respect to pulmonary embolism, in the initial slide, Nikitha had mentioned the patient can have hemoptysis. Okay, that is because in pulmonary embolism, your pressure or your pulmonary capillary pressure is very high because of the block. So that time the blood vessels can rupture into the bronchioles and the patient can have hemoptysis. So this is with regards to an obstructive shock. So I'll just summarize it again. Okay, first and foremost, as a surgeon, you need to be aware about hemorrhagic shock. Sorry, the hypovolemic shock. It has 2 components, either blood loss or fluid loss. If it is blood loss, first and foremost, you resuscitate the patient with IV fluids. Look at their response. If the response is good, you continue resuscitation. If the response is bad, that means you need to take up the patient for surgery and arrest the bleeding in whatever form necessary. Next, coming to septic shock, you need to know about what is the surviving sepsis campaign and what are the components of the bundles. And now the latest one is the updated 1R bundle. And you need to identify the source of sepsis and the surgeon's role in control of the source of sepsis, and treatment accordingly with respect to whatever antibiotics and vasopressors that are essential. And with respect to obstructive shock, whatever the immediate treatment or the immediate management that is necessary in order to relieve the obstructive shock. Cardiogenic shock, not a very important topic from your exam point of view. Any questions or doubts from the postgraduates? Or even comments? Oh, Pawan is the only one. Pawan, any doubts, comments?
Sir, I have one doubt, sir. Sir, how mixed venous saturation and central venous saturation differs? How will we monitor? And I have small doubts.
Nikitha, do you want to take the question?
Sir?
What is the difference between mixed venous central oxygenation and central venous oxygenation?
The central oxygenation is taken from a pulmonary. I'm little confused, sir. As far as I read, they both were taken from pulmonary artery catheters.
Put it up in our group, because I think giving wrong answers may not be helpful. So, I think read up again and put it up in the group.
Okay, sir.
That will be better.
Anybody?
Unless Nishant wants to answer that question.
No,
Otherwise, they need some homework.
yes. Good from your. Pooja, Abdul, any comments from your side?
It was a very good session, sir. Very informative.
Abdul?
It was a good session, sir, and all updates were reported.
Any other seniors before I move on to Ravi Shankar sir and Lakshman sir?
She presented well, sir.
Oh, Indraja is back, yeah.
Yes.
Correct. I wanted you guys to talk about her presentation. This is the first
Yes,
presentation.
sir. She
And
presented well and slides are also good, sir.
yeah, and what's more important is she hasn't copied this straight out of a textbook. Okay, that's extremely important when you're giving a subject seminar, that you do the reading. I was surprised when she sent me the slides. I had to go back and read about a lot of them when she sent me the slides. Okay, Ravi Shankar sir.
Yeah, I think, but not just because it's the first presentation. I think she did very well. The slides were good, and I think she never. I think most of the time she didn't read out of the slide. The slide layout is what we usually advise, and she didn't read. She explained, tried to explain things, and the hesitation will go as she does more and more presentations. I think it's a very good effort. Not just because it's the first one. I think I think she's put in a lot of effort. Well, for other postgraduates, this one.
Lakshman sir.
Yeah, I agree with, am I muted? Yeah. Yeah, okay. I agree with whatever you guys have said. I think it's a very good effort. Congratulations, Nikitha, and congratulations, Nishant, for guiding her so well. I know that you did a lot of work on correcting her slides, and I'm sure you will, if you continue your effort, during your course the way you have done now, you will reach great heights. Congratulations again. And I have put up the difference between mixed venous and central in your chat box. You can see that one refers to the SVC, other one to the pulmonary artery.
Okay.
It's the same oxygen saturation that you do.
Nice.
Okay.
So final comments from my side. I just think that our time management could have been better. I think we spent too much time on hypovolemic shock and kind of ignored septic shock, which is also an equally important topic because it's a 10 marker in my final exam. And Nikitha, very well presented. And like I've told you before, also, I was very impressed with your slides and the amount of reading that you have done apart from what is available in the textbooks. Very well done and congratulations.
Yeah.
Thank you, sir.
Just
Thank
to
you,
just
everyone.
yeah, sorry, just to say again about this mixed venous. This
Yes.
mixture is from the blood of superior vena cava and inferior vena cava. So that's what reaches the pulmonary artery. Okay, central is only SVC. So when the blood from the SVC and the IVC mix up, then it's a mixed venous oxygen saturation. Okay.
Okay.
All right.
Nishant,
Right.
I think, Nishant, one more statement. I think this is an appetizer. All of you need to go back and read and, get your concepts, strong, because shock is not only for exams, as Lakshman sir keeps saying. I think we are trying to prepare you for life. Exam is just a interlude. That's all. So for you to manage your patients properly, you should know how to manage shock. So you need to read up properly.
All right, then. Good night, and I'll close the meeting here.
Thank you, sir.
Thanks.
Good night. Good night.
Good night.
Thank you, sir. Good night.
Yeah.